Welcome to Ask Dr. Mingle, the Q&A series from Mingle Health, where we take your questions about quality programs and the transition to value-based care. My name is Hadley Taylor, a MIPS quality program consultant. I'll be hosting this episode along with Dr. Dan Mingle, founder and CEO of Mingle Health. Good morning, Dr. Mingle.
Good morning, Hadley, and good day to all of you tuning in. It's great to see you again. I am Dr. Dan Mingle. I'm here to answer your questions to the best of my ability.
Before we start, I want to invite all our listeners to send in your questions. You can leave the questions in a comment on LinkedIn or on YouTube, or you can email them directly to us at hello@minglehealth.com. All right. Our first question today is from Turner. Turner wants to know, for an ACO's first performance year, are you eligible for shared savings as a result of just reporting? I'm having a hard time keeping up with the most current versions of the CMS technical guidance, and I see at one point that was the case.
Great question, Turner. Thanks. And you're not alone. A lot of people get confused by CMS technical guidance. For an MSSP ACO in its first year, reporting is pay for reporting. Just submitting the report earns full shared savings. But that's not the whole story. Any MSSP, that is Medicare Shared Savings Program ACO in its first year, is likely to be a MIPS APM. In fact, I'm not sure of any exceptions to that rule. The APP quality submission is also used to determine the MIPS adjustment. The quality is pay for reporting for the MSSP share of savings. The quality scores pay for performance in calculating the applicable MIPS adjustment for those of your participants who are participating in your program as a MIPS APM. Hope that helps, Turner.
Our next question also comes from Turner. What is the current weighting for the measure vis-a-vis the administrative claims and the experience of care results?
Another good question, Turner. All Medicare Shared Savings Program ACOs are now subject to the APM performance pathway scoring. The APM performance pathway is usually referred to by the acronym APP. There are three options this year and next, that is 2023 and 2024, for the quality portion of the APP score: web interface, eCQMs, or MIPS CQMs. No matter what method you choose to submit, CAPS is a single composite score. That's the Patient Experience of Care Survey measure. CAPS and two administrative claims measures are weighted equally with each of the submitted measures for your final quality score. In the case of eCQM and MIPS CQMs, there are 6 quality measures that each have the potential of 10 quality points. That is 3 that you submit, the CAPS measure, and 2 administrative claims measures that Medicare calculates. Participants will receive a score between 1 and 10 for each of the 3 submitted measures, each of the administrative claims measures, and the composite score for CAPS. The final score is the total score achieved divided by the 60-point potential. That in turn is multiplied by the total possible quality points in the APP MIPS quality score. Quality usually counts for 50% of APP MIPS scoring. It's 75% if your ACO qualifies for and takes advantage of the reweighting for promoting interoperability. In the case of a web interface submission, 8 of the 10 measures in the web interface are scored, counting for 80 potential points plus 10 points for each of the 2 administrative claims measures and the composite CAPS score. The final score is the total score achieved divided by the 110-point potential. So the 2 administrative claims measures and the CAPS Experience of Care measure composite are weighted 30 out of 110 points in a web interface APP submission, and they're weighted 30 out of 60 points in an eCQM or MIPS CQM submission. Hope that helps, Turner.
Thank you. That was definitely a great question, wasn't it?
Yes.
Today's third question comes from Emily. She would like to know, do you have resources available to prepare for reporting an eCQM from both the perspective of EHRs and as a practice?
Great question, Emily. I'll begin my answer to the question by explaining that I don't recommend eCQM reporting. We have always maintained qualification by CMS as a registry. And for a time, we simultaneously maintained certification through the ONC as an eCQM vendor. We dropped certification for eCQMs because it added cost and effort to our products and services without adding value for our clients. Specifically, certification is kind of a process measure for quality reporting or of quality reporting. It shows that a vendor can understand the specs, understand standard data and nomenclature, and with using an idealized data set can generate an accurate set of analytics. In contrast, qualification by CMS of registries is more of an outcome measure applied to quality reporting. Registries are requalified annually in a process that is ultimately confirmed by audit of its output. If you produce inaccurate analytics, you will ultimately stand to lose your qualification. Production of eCQMs is rigid and uncompromising. It's exclusive, restricting the vendor to a standardized data flow, standard nomenclature, and a fully certified pathway from the patient through documentation to data extraction, analytics in the data display. But we find that real world data is just far more confusing and complex than is tested in the certification process. The registry process that produces MIPS CQMs, in contrast, is inclusive. Registries can use all of the data sources that eCQM vendors can use, but all other data sources are also available to us. As a registry, we are restricted only by the verifiable accuracy of our output. eCQM quality benchmarks are often more favorable than our MIPS CQM benchmarks. Typical scores are lower on the average for eCQM submitters than for registry submitters. Scores are lower because they tend to miss more documentation elements. It's less accurate reporting. If your clinician users don't adhere rigidly to prescribed documentation standards, eCQM processes can fail to identify the quality action. In contrast, registries can expand the query to additional fields, additional search terms, additional data sources to serve your clinicians where and how they document. You can even look at your output of performance not met and do double checks manually to your failing charts to see if it was met in another way or in a text field. Now, we have an abundance of resources on our website to help you prepare for and succeed with MIPS or APP quality reporting. We cover reporting from the EHR and reporting from other sources. Common sources of data for quality reporting include the practice management system, flat file extracts, or 837 or similar claim file transmissions, EHR flat file extracts, EHR QRDA1, other HL7 CDA documents, or FHIR, the so-called FHIR transmissions, disease registries, tumor registries, manual abstraction of paper charts, or even manual abstraction of electronic charts. Any and all of these can go into a winning submission through a registry.
Our fourth question today is from Will. Will would like to know, I heard that CMS has declared again that there is a COVID EUC Hardship Exemption available for the 2023 performance year. Does that mean we don't have to submit anything for MIPS in 2023?
Great question, Will. Before I get into expectations for the 2023 performance year, let me point out that Medicare is still accepting applications for COVID hardship exceptions for 2022. Medicare is accepting applications until March 3rd. For 2023, the answer is maybe, but consider carefully before you skip your 2023 submission. Medicare is not granting any special consideration for COVID for 2023. They're simply stating the obvious, that you can always apply for a hardship exception for any reason if you believe one exists for you for any reason, including COVID. Now, I'd also like to point out that I've just heard in the news that the intention of the White House is to end the official public health emergency on or about May the 11th. So by the time our next reporting season comes around, and certainly for more than half of the performance year, we expect to no longer be in a COVID health emergency. Regarding this new announcement about COVID hardship exceptions for 2023, the first thing I observe, and it's not an automatic exception, as has the first 3 COVID affected submission seasons. In those years, if you did not submit, Medicare applied an automatic exception and non-submitting providers were not subject to any adjustments. So far for 2022, and the expectation for the 2023 performance years is you don't get an exception without applying for one. We are late enough in the submission season for 2022 data that we're unlikely to see an automatic exception added to the 2022 submissions year. I don't think we'll see one for 2023 unless there's a new variant or a new infectious agent that is more infectious and or more fatal than what we are now seeing. Second, observing that COVID still affects all healthcare practices to some extent, and the exception is not automatic, expect it to require more than just the existence of COVID to warrant an exception. Your application should reflect how COVID is in the way of your participation. Did key clinicians or support staff suffer prolonged infection-related complications? Was your community or practice overwhelmed with COVID or complications? Did you use practice resources to upgrade your infection control infrastructure? Third, on the surface, this is a meaningless reminder. It should now be obvious to everyone that COVID is here to stay. And the hardship exception applications have always been available to quality payment program participants. We should expect always to be able to apply for an exception for MIPS on the basis of COVID-related hardships or any other hardships. I don't expect Medicare to ever say there will be no more hardship exceptions granted for COVID. Fourth, by choosing to remind us Medicare is encouraging us to use the hardship exception, and by encouraging it are implying an intent to be lenient when approving applications. Because Medicare issued a reminder, I expect more practices will apply for hardship exceptions than otherwise would, and I expect a high level of approval. But a fifth and final warning. Though it's reasonable to expect leniency, you won't know until Medicare starts accepting and acting on applications just how lenient they're going to be. And the degree of strict or lenient we experience early in the season may not be the same as late in the season as the political and infectious environments evolve. Whatever you experienced last year may not be your experience this year. Whatever you experience this year may not be the experience next year. Apply for an exception if you need it. Support your application with concrete and credible observations. Don't assume acceptance is going to be granted until it is. Will, I hope that answers your question.
Excellent. Deep breath. That was a good one, Dr. Mingle. And one more to go. You ready? Our final question today is from Janet. She would like a little more clarification on a question that was asked last week. She says, I am still uncertain what my MIPS susceptible ACO participants need to do for MIPS reporting. Could you explain this in a little more detail, Dr. Mingle?
Thanks, Janet, for pushing for better clarity. Let me give it another shot. Of the 4 MIPS categories, 2 categories require submission. Quality counts for 50% of the total MIPS score. Medicare will repurpose the APP quality submission to count toward MIPS. If the ACO makes an APP quality submission, everyone who needs a MIPS quality score will be assigned the ACO's APP quality score for MIPS. But that's not the whole story. There may be some occasions where you want some of your participants to put in a separate and distinct, more personalized quality score. Remember that the APP quality score represents the average performance across the whole ACO, all of the participants. So half of your participants would get a higher score on their own, and half of them would get a lower score on their own. And maybe half of each of those, it would be significant enough, or at least half of the higher group, it might be a significant amount higher to make it worth a separate submission. Your top performers should consider making a separate MIPS quality submission either as an individual or as a TIN, as a practice group. Medicare will grant the highest available score to any participant. If they get a higher score from their individual or TIN group submission, they may get a higher MIPS adjustment. Promoting interoperability, that is PI, also requires submission. It counts for 30% of the total MIPS score for MIPS APMs. Each of your MIPS susceptible participants needs a promoting interoperability submission to earn any of the 30 points toward the total score. Now, participants can exclude from promoting interoperability for any of the reasons Medicare offers exclusions, including small practice or hospital-based practice exclusions. Otherwise, a submission can be made by the individual. It can be made at the TIN practice group level. And starting in the 2023 performance year, the APM entity can make one submission for the whole APM participating provider group. Now, promoting interoperability scoring works differently than quality scoring. In quality scoring, if you're a high performer, you could get a higher quality score on your own. With promoting interoperability, you really get the highest score applicable to the whole group. So you should never be able to get a better score than the APM group score. That is if all the data were pulled together and reported accurately. Now, two MIPS categories require no submission. Cost never gets submitted by anyone. Medicare calculates cost measures from administrative claims. But also for MIPS APMs, cost is not scored. Cost does not contribute to the MIPS score at all for MIPS for any MIPS APM participant. Medicare judges that they're already getting financial penalty or gain through the shared savings aspects of the APM. Improvement activities also does not require a submission. It counts for 20% of the total MIPS APM score. No submission is needed for improvement activities by APM participants. Medicare knows who you are and automatically assigns the scores. By legislation, APM participation always counts for at least 50% of the total possible improvement score. Medicare assigns additional improvement activity points if the APM design warrants it. So far, all APMs are good for full credit for improvement activity. And again, Medicare knows who you are, knows that you're due those points, and does not ask for submission to establish that and grant the points. Finally, I want to issue a factual clarification for an answer I gave in the last session. Janet asked the question last session about ACO quality submissions and MIPS APM submissions and the earning of APM incentives versus the MIPS incentive. I continue to stand behind my answer to the core question. No provider is eligible for both the advanced APM incentive and the MIPS incentives in the same year. I also reported accurately that the 5% advanced APM incentive ended after the 2022 performance year. It will be paid in the 2024 payment year. But I missed new legislation issued in December 2022. The Advanced APM Consolidated Appropriations Act for 2023 established one more year of advanced APM incentive. The incentive is reduced for this additional year from 5% to 3.5%. It's available only to qualified participants in an advanced APM in 2023. It will add 3.5% to all Medicare payments to qualified participants for services provided in 2025. This change fills a gap. In 2026, qualified participants get more favorable payments through Medicare's physician fee schedule. That is, every year when the new physician fee schedule comes out, APM participants get a higher fee than do MIPS participants or those just getting fee for service. Before this legislation, 2025 would have been the only year that the qualified participants received no incentive in the lapse between that the QP 5% incentive and the favorable PFS, that is a physician fee schedule conversion rates. Sorry about the confusion. This should clear things up.
Excellent. Thank you so much, Dr. Mingle. Turner, Emily, and Janet, thank you for the great questions. If you have a question for Dr. Mingle, please leave it in a comment on LinkedIn or YouTube. And you can always send us an email at hello@minglehealth.com. Dr. Mingle, that was a good one. Thank you so much for sharing your insights with us today. I know it helped our listeners.
Thank you, Hadley, and thank you to our listeners for all the great questions. I want to be helpful and I want this to be useful to you. Don't hesitate to correct or supplement my answers. Share your own experience or ask your questions. We can be smarter together.